Yes, it would be nice to have some guidelines, like to say, yes, it's, if a women have this and this and this capabilities, then you can begin to do this, and then the progression of the impact loads, to know more about this.
You're listening to the Active Mom Podcast with host Dr. Carrie Pagliano. I'm a mom, physical therapist, and your go-to guide for staying active with pelvic health issues in pregnancy, postpartum, perimenopause, and beyond. Whether you're a fellow mom, physical therapist, or women's health professional, join me where I'll share expert insights, real-life stories, and the latest research to help you approach running, CrossFit, yoga, Pilates, HIIT, or whatever activity you love with confidence and evidence-informed guidance. Let's start the show. Welcome back to the Active Mom Podcast. I have a great guest today. She was probably one of the first that I remember reading research on what happens in the pelvic floor during impact and jumping and running. And she's finished her doctoral work and then is going on to integrate more of that in clinical practice. So welcoming Helene Moser to the show. Welcome, Helene.
Yeah, it's a big pleasure to be here and to talk about my work and the implication that I did in practical work.
Wonderful.
Right.
Tell everybody where you are in the world and where you practice, and then we'll start talking a little bit about your research.
Yes. So I'm from Switzerland, and I have my practice in Bern, capital. And there I also work like a teacher in the Bern University of Applied Sciences. But most of all, I work in my own practice. And then I implement what I studied and what my research. I do it in the practical work from day of day with the women. They come to me, and I bring it together with the knowledge I have from the Franklin method, where I'm a senior teacher, and I know it about 30 years. So for me, it's great to have some scientific background, but also a lot of background from the feeling and how pedagogy of movement and how you work afterwards with the clients.
That's wonderful. No, I had mentioned before we started recording, I had taken a class from Eric years ago when he came to the United States with the American Physical Therapy Association at one of our combined section conferences. And so I'm familiar with that. So I'm curious to see how you combine your research with some of that movement. I think it's going to be a great conversation. So tell us maybe first why you decided to study impact and the pelvic floor.
Yes, that's a thing, because the pelvis is the center of the body. So it's the center of the movement. And then it's very interesting to work with the pelvic floor. And then it's the second part that women have problems with it. But for me, it was more interesting to see, that's so important for movement. And if you really have the feeling that you do each movement from the pelvis, then your pelvic floor will also strengthen more than if you do the movements, for example, more from the arms and the legs, and you're not centered, and you don't use your trunk muscles. And that's why I was very interested on pelvic floor. And then I decided to do a master of science, and then from there I published something about how you can measure the displacement from the pelvic floor. And from there, then my tutorial person had asked me to do a doctoral work together with a colleague of mine. She was studying more running, and I was studying more jumps. So it was coming like this.
That's a lot of work. So maybe
Yes.
start with you did a little bit. You mentioned talking about displacement of the pelvic floor. Maybe we start talking a little bit about that.
Yes, maybe we can talk about this because displacement is interesting. Yeah, maybe I can ask you, what do you think how the pelvic floor will displace during a jump, if a landing, let's say a landing, when you are landing, what are you thinking uh, will the pelvic floor react
I
when you
think
land?
we want to know. I mean, I think the hard part is um, for, I think, us as physios who work in this space, we know it's not static. We know it does something. But I think the hard part is knowing, when you have anticipatory movement, and I think the other thing too is normal versus what we see all the time. And I think, we tend to work with people that have issues when we're not even clear on what happens in normal movement. And
Mhm.
you initially looked at normals, or did you start with, because you did some systematic reviews in there as well?
Yes, I did some systematic reviews, and my colleague did it for displacement, and I did it for the muscle activity
Mm-hmm.
to know a little bit more if the activity is eccentric or concentric. So uh, that was the question about it. But the thing is, we thought when you are landing that the pelvic floor is like a trampoline. He goes down and then he goes up. In the initial, we thought that's that. But interesting, that's it seems so. We haven't done a lot of studies, but the tendency and what we have seen is that when just before landing, he goes upward.
Mm-hmm.
So when you are in the air, he's down, relaxed. But before landing, so the pre-activity of the muscle is reacting and he will go upwards.
Mm-hmm.
And it seems like he tries to close when the impact is coming. So it's not at all like that we thought. We thought it's like a thing that he has absorption and he goes backward. It's not that. It's not an absorption. He tries to close first,
Mm-hmm.
and then it's coming. I think this is very important to know this.
When you were looking at the displacement, what type of measurement device did you use, and do you think that played a role in what kind of your findings were? Because it's a hard place to measure, obviously, especially
Mhm.
with it
Yes.
moving so much.
Mhm, mhm. Yes, that's a big difficulty. And we used an electromagnetic tracking system. And then the fixed point was at the sacrum. So like placed
Mm-hmm.
like on the sacrum. And the other one was placed at the vaginal probe. So we measured not the displacement directly of the pelvic floor, but we measured the displacement of the probe.
Mm-hmm.
But so that's a little bit the same. And then the difficulty was it needs to be a little bit fixed in the
Yep.
vagina, because it could also be that the probe is moving and not the pelvic floor.
Right.
And for this, we used a sponge,
Mm-hmm.
and this was quite fixed in the vagina.
Mm-hmm.
So we could think, yes, it's okay. And then we controlled it, the data. If there are some irregularities in the data, and this when there was irregularities, we put them out. So when we had the data, we controlled a lot
Mm-hmm.
to be sure, yeah, that's normal measurements.
As a clinician now looking at that information for displacement, how do you apply that information now with your patients that are in front of you? Does that change? Did that change how you worked with your patients?
Yes, then the knowing that it goes upward before you're landing. So because I'm coming from the Franklin method, I tried it. And then I tried, how does it feel if I do the contrary? I think it goes down and then up. And how does it feel if I think it goes up when I'm landing? And if you do it, you feel it. It's clear. It's more comfortable to think he goes up. So I use the imagery to activate the pelvic floor in an unconscious way, involuntary. And that's also that we think from our research team. It's important to make a training and to make it better, the involuntary activity of the pelvic floor.
Right.
And I found also training systems, not for pelvic floor, but for running or something like this. You can really train this, that the activity is coming faster because it goes about reflex. There are short reflex, mid reflex, long reflex. And we found with the activities we measured by landing and also by jumps, then we have found when you do a landing, it needs 30 to 60 milliseconds for the peak activity of the pelvic floor. So first you have a pre-activity and the reflex activity. So the pre-activity means that we measured 30 milliseconds before the impact. And for example, running, if you run this 5 kilometers in an hour, in miles, I don't know how much
That's
it is.
okay. We'll translate it. It's okay.
So then the reflex, the pre-activity is higher than the reflex activity. It's interesting. So the pelvic floor goes up. And because the impact is not so high with 5 kilometers, it's the highest strength or activity that it needs is in the pre-activity. And the reflex activity normally after 60 milliseconds, it's over.
That's very
So
fast.
very fast. And then in landing, if you are running, because you have also to jump up, then it needs a little bit more time. But it depends how fast you are going. And that means if you do a voluntary contraction, then you need 500 milliseconds. You can try it. If you do it as fast as possible, it needs about this time. So that's half a second. So it's important for a training for involuntary activity. So all data are showing this. And the other thing that we have seen is that it's not all or nothing. It's not a reflex and then you have all or nothing, but it's if you jump a little bit, it's less, and if you are going higher, it's more. And that's for a clinician to think, yeah, that's normal, but that's not given like this.
Right. No, that's true. I was
Yes.
interested earlier, you were referencing how you applied this concept with what you know about the Franklin method with your work with them. For someone who doesn't know anything about the Franklin method, could you give us a quick kind of introduction to what that is and what that imagery is that you're now starting to work with a little bit?
Yes. So maybe the idea is that you use an imagery that's functional and you don't do it. Don't, but you image it so that it helps you the involuntary activity of the, here it's the pelvic floor to activate. So it's quite easy. The image that I use now is before landing, you think the pelvic floor goes up. Just easy. So everybody can do it. And then I like the women, for example, do something like steps, little steps, step and go. And each step you stop, you think the pelvic floor goes up.
Mm.
So I begin with little things like I'm standing and I make a step forward, I make a step sideward, backward, diagonal. And each time I'm landing, before I'm landing, I think the pelvic floor goes up.
Mm-hmm.
So it's quite easy for everybody that has no idea from Franklin method to do
Right.
this.
I'm thinking of somebody gave me a cue once with jump roping to help with pelvic floor control with leaking with my eyes, not my head, but just my eyes to gaze up towards the ceiling in the gym. And just that, it's funny, in some people, that small cue of a lift does make a difference. But I think, for somebody that's not familiar with using imagery or things like that, there can be an effect with patients that's more beneficial with something that's automatic or anticipatory that we're talking about here versus doing a conscious, like cognitive Kegel or something like that. You might have a better effect with just that cue. What could you give us maybe some examples of how you might use this with one of your patients?
Yes, for example, like I told you, I begin with these steps, and also I make them to be aware if I do the other image that the pelvic floor is going down, that they feel, oh yes, it helps. That because you have to be convicted about something, otherwise you don't want to do it.
I see.
Yes, and then it depends a little bit if she wants to go for jogging or if she wants to do volleyball or something like this. So I do more jogging or I do more jumps. But often I begin with these side steps, stop and go, tuck, tuck, tuck. And then from little ones, I make it bigger. And then I go from really jumping on one leg. So I have a little bit this progression of the intensity. This is the first thing. And then if this works good, the person has no problem, then I want to train a little bit reactivity, the force, strength, training of the reactivity strength. Do you tell it like this in English?
I think so.
It's
Say
like
one more time.
the strength of reactivity. It's
Okay.
training for like power training. I think it's
Yes.
power training in
Yep.
English.
Yep.
Like
You're
in
doing
German,
great.
it's different.
You're doing great. I can't speak German. I'm sorry.
Yeah. So it's a power training. And often in the pelvic floor rehabilitation, we stop at muscle strength training. But I don't know, because after 12 repetitions, maybe you can do the next one, the 13th one, also correct.
Right.
And normally, if you want to do a strength training, normally you do 8 to 12 repetitions maximum. That the next one you shouldn't do it correctly. And when you had 12, then you take a higher weight, and then you begin with 8, and you go to 12, and then you do these 3 repetitions. Yeah. But with the pelvic floor, how you want to do that?
Right.
Difficult. So we think we do strength training, but I think we are, I don't know, maybe a little bit about endurance, maybe strange endurance, maybe some women, they are really not a lot of strength, maybe yes, but the majority, they have no problems. They don't do a strength training.
Right. No, Go ahead.
Mhm. So this thinking, but then we stop often. But if you do a knee rehabilitation, you don't stop there.
Right.
You do jumps afterwards.
Right.
You do this power training. And in the pelvic floor training, rehabilitation, we say, no, jumps, that's dangerous. Don't do that with the descents, the pop. And yes, for sure, you can't do it with every woman. It's not indicated. So you have to screen a little bit which one you can do it and when you can do it and how it is, the progression. And for this, we don't have enough studies to say you need to have this and this, and then you can begin with strength training or with jumps. And also we discussed a lot, can we do jump training with or without loss of urine?
Right.
We don't know it.
Right.
Maybe you have to do it individually and to see what is the problem and how does it react the women and everything. It's not, each woman is different.
Yes.
So
and you looked a little bit at muscle activity in women who were continent and not incontinent.
yes, we do.
Tell us a little bit about what you learned, because you did I think you did a systematic review first and then the exploratory study. Tell us a little bit about both of those.
About?
Yep.
About what?
Just I'm guessing at the time, I mean, there really wasn't much that we knew for a systematic review. And then you started the exploratory study. What were you looking to figure out?
Yes, this is. So in the systematic review, I think I did like categorizations because there were quite a lot of things. And one is the time to react. And it's the continent women, they contract normally the pelvic floor before the trunk muscles, like cuffing or something like this. So it needs first the pelvic floor and then the trunk muscles. And the incontinent women were at the same time or a little bit later. So in the end, for me, this is quite one of the most important things. The time when the women contract the pelvic floor, even more than the strength that they have. So we need to train this, that they learn to activate the pelvic floor rapidly. And this, I think you can do first, you have to relax.
Right.
The pelvic floor. We did one study that we have seen, we did a fast voluntary contractions with continent and incontinent women. And then we have seen that the time to peak, that was the same for both. But then the time to relax, the incontinent women had a longer time to relax. So that a lot of us, we already tell, we have to relax the pelvic floor. It's not nothing new.
Right.
But we have seen it. So that's an interesting thing. So we have also that the women learn to relax the pelvic floor. And for me, this then is thinking, why they don't relax? Maybe they have bad posture. So then I do always strengthening the psoas muscle. I'm a fan of psoas muscle. So I'm training the psoas muscle, because for me, it's the central muscle that gives you stability of the body. And it means if you have the stability from the center, you don't need the oblique, you don't need the rectal muscles, which augment the intra-abdominal pressure. And then it needs also a lot of the work, like Hodge did a lot with the instability of lumbar spine problems, and then he found the person, they have like a co-contraction, they have more pelvic not pelvic lumbar problems, then that they have more, the deep muscles are activated. So we have also to think about this, that the stability and that the deep muscles of the trunk are working well. And this will also have that the women have less intra-abdominal pressure during rest, because this is also important, that if a muscle needs more than 30% of contraction, then the circulation will be bad and the muscle will begin to be weak. And in rest, normally, if you are standing, you need about 20-25% of the muscles activity of the pelvic floor in normal cases. But if you have a bad posture, or you use too much intra-abdominal pressure, maybe also because the breathing patterns are not good, then the pelvic floor will have more than 30%. He will be bad circulations, not enough blood to go inside. And he will getting weak and hypertone.
I see. So you're saying a less than ideal posture will change an activity strategy of the muscle because it's responding to that pressure change. Is that kind of what you're saying?
Yes, because you don't need so much intra-abdominal pressure to be on in alignment. So for me, it's important also to look at this. But I was in the systematic review.
Oh
I'm
yeah,
sorry.
that's fine. No, you're good. You're good. Keep going.
I was a little bit. All right.
That's okay.
So time of activity, the reaction time that we need to be better. And there was an interesting study from Deville. She's a French, and she did. She let women, first continent women, cuffing, introduce cuffing, and she did it once like this, and once they distract the women. And when the women was distracted, the time to activate the pelvic floor was greater. So when you are not distracted, the activation was earlier, and when you are distracted, it was later. And with incontinent women, the cuffing and the contraction when we are not distracted was on the same time. And with the continent, it was a little bit before. But when they were distracted, the activation time was after the cuffing.
Oh, interesting.
Interesting. And I thought, yeah, but if it's possible in this direction, it has to be possible also in the other direction. Because I work so a lot with imagery. So to know when you are cuffing, the pelvic floor goes upward, it will help. So if you know, then you already think he will go upward. You don't do it, you think it. So you don't do the neck, but you think that it will go upward. It should help also.
Oh,
But
that's interesting.
It's no study about this, but this would be very, very interesting to do a study about this.
I was going to say, when will you do the study? I had a question for you about you had mentioned how with incontinent women they took longer to relax, and so we wanted to speed up the relaxation with the pelvic floor. How once you've identified that might be an issue with a patient, what are some techniques that you might utilize to try and speed up that relaxation?
Yes, there are different things. First, I let them sit on a ball to relax the pelvic floor, everything to relax the pelvic floor. No?
Mm-hmm.
And then I use also the ultrasound,
Mm-hmm.
transperineal ultrasound, and also transabdominal ultrasound.
Mm-hmm.
So they can visualize it
Right.
by biofeedback.
Yes.
So I use a lot biofeedback that they see it, they contract, and I tell them it's not important to contract fully, but
Mm-hmm.
the most important thing is just contract and relax.
Mm-hmm.
Just relax. And then I do this with them. I give them they have to do it at home,
Mm-hmm.
like 3 series of 10 of them.
Mm-hmm.
And the importance is to learn to relax
Mm-hmm.
fast. And sometimes I do also, if it's really a big issue and a big problem, I do it that they have to relax it slowly.
Mm.
Like we have in the Franklin method, we have a thing for the trapezius muscle
Mm-hmm.
that we take it up and we let it down slowly.
Mm-hmm.
And then you do some imagery. The scapula is like soap, it's going behind, and you let go it down slowly.
Mm-hmm.
And normal people, they are not used to it. It makes
Right. Yeah.
and to learn to do it slowly.
Mm-hmm.
And the idea behind is, I don't know if it's really like this, is that you think each fibers are going outward,
Mm-hmm.
and that the nerve has to tell each fiber, now you are relaxing, now you are relaxing, and now you are
Yeah.
relaxing.
Yeah.
So, and that's a slow eccentric work
Mm-hmm.
of the muscle, and this is for relaxation of the muscles. So sometimes I do also this,
Mm-hmm.
that they have to go slowly down, and I do it with biofeedback.
Mm-hmm. I think slow is it's a challenge because
Yeah.
you have to work on that control, but it's, to your point, I think if you practice fast first, they don't know how to do that yet. They haven't figured that piece out. So starting in something where they can get there and then come back up, they can get there and repeat that. I like that, to be able to find something that you can do and control it. And then I'm guessing you would speed that up from there.
Mm-hmm.
Yeah. Now, at what point would you decide to, I'm assuming you would start this with the pelvic floor. At what point would you decide to start to do impact exercises to accompany the pelvic floor, and where would you start with that?
Mm-hmm. Yes, first I look that they can contract it correctly and the breathing is correctly, and do strange work for strengthening. And I do a lot of also strengthen the pelvic floor in functional movements,
Mm-hmm.
like squats.
Mm-hmm.
And then you imagine you go down, the pelvic, the tuber is ischiatic because they go outward, and you go upward, it goes together. That's a classical image from Franklin method, but I think everybody is doing this.
Mm-hmm.
I think so. And I do this, and then I do exercises also sitting.
Mm-hmm.
That I do the backward tilt of the
Mm-hmm.
pelvis, and I imagine that when you are forward in a forward
The
flexion of
anterior
the
tilt. Yep. Mm-hmm.
anterior tilt,
Anterior. Mm-hmm.
anterior tilt, the tuber are wide, and
Mm-hmm.
you go actively together with the tuber to do a backward tilt.
Yep.
Then
The
you
posterior.
go
Yep.
the person. And I think this is very important to learn this, because if you are throwing a ball, if you see me, then you do it from then you do it from the pelvis, and you have to learn this. That the movement is the beginning of the movement is the pelvis. So I do a lot of strengthening of the pelvic muscles, but in a functional way. And I let them also do the classical one, contraction, and you hold it and you go on. I do this, but then I do it quite fast in these functional ways, different things, in lying position, in sitting position, in staying position. And I do always with function. And if this is going well, they already trained longer and they have a strong, the strength is given. But maybe they say, yeah, I have leakage when I go running or something like this. Then I begin with these little steps. I let them do this. I let them do bigger ones. And then I do this power training. That means power training is about when I do a jump. If I do a quartz jump, so it's a different kind of power training, or if I do a counter movement jump, then I do 6 of this. And then I do a long rest time, and I do 3 times 6 for the power training.
Okay.
So I don't tell them, yeah, then you go 15 minutes for running. Then that's more endurance. So I do really power training. So they have to jump as high as possible, and but only 6 ones, 6 times. And if this is going well, and then I can also try with strap jumps. Or first I begin with strap landings, because it's less demanding, the pelvic floor. And then I do the drop jumps. And with these 6 repetitions, and then I go always a little bit higher. So, for example, and if this is going well, then I go for the endurance of power training. And I let them do 30 repetitions.
Okay. Do you find that typically once they can do the 6, the 30 is pretty easy, or then you might have a problem with endurance at that point? It might take a little bit longer to get to the 30 without symptoms.
It's difficult to say.
Yeah, it depends.
It depends really.
Yeah.
So it's
I like the
yes.
concept though that we're focusing on power. It's really going to be those 3 sets of 6 reps, which really goes back to our strength and conditioning training. And then we change the phase and look ahead at endurance. I like that.
Yes.
Anything else before I go on to some additional questions? Any other things that you want to be sure that we know about the studies that you did?
Yes, there are some interesting things. For example, if you do the stairs, going up, going down, an interesting thing was it doesn't go up and down and up and down, up and down, or activity, relaxation, the pelvic floor. It stays up in a high activity and it stays there. That's interesting. But it seems like pelvic floor sees, here we have impact that's coming, and we try to let it high. And I don't know why. It seems like this.
Is there fluctuation at the high, or it just stays?
No.
Oh,
No,
interesting.
it's high. Yeah, it's interesting. And you don't even see when the step is coming. You don't even see a peak.
Huh.
That's interesting. So it seems to do stairs, it's not so big training to do this. It's good for the legs and everything,
Yeah.
but the pelvic floor seems it's not so big deal.
That's, I'm thinking clinically, sometimes I have patients with difficulty relaxing that they'll do an activity, an intense activity, kind of like stairs or things like that, and it stays up. And we talk about how afterwards it's important for them to give their pelvic floor time to relax after they finish. And for some people, that can be incredibly helpful to just, lay on the floor and put your legs up the wall, or just some breathing to get the tension back down or the tone back down. It sounds like that possibly might be the reason that is helpful, is because if we are doing that activity, it's going to stay up.
Yeah, maybe.
What else?
Yes. Then we looked at trampoline. So with different speeds. And the interesting thing is, because a lot of women have problems with the trampoline, that's one of the most difficult.
It is.
And we have seen that the impact isn't as high as you are doing a drop jump, but it's much longer. And that's, I think, it's difficulty. Because you need to have a strong contraction during a longer time. So that seems that's difficult for the pelvic floor to do this.
Stronger for longer for trampoline.
Stronger for longer, yes.
Okay. How long did you look at them on the trampoline?
Oh,
do you remember? It's okay if you don't.
Not so long.
That's okay.
No, not so long.
Okay.
We just looked at on the speed and at the changing of the activity on the speed.
Okay.
Yes.
Okay.
And then we looked this with the first one is important. How long is the activity of the pelvic floor?
So it really does depend. You're finding it depends on what activity you're doing, what the performance and the function of the pelvic floor is. It sounds like, yeah.
Yes, and then we have found that the most difficult thing then from the impact, the most highest impact is drop jumps. This is really something that the pelvic floor is activated a lot. And then counter movement jumps and less than just landings. And it's also, that's clear that if you do a landing from 5 centimeters, it's different than if you do from 40 centimeters.
Right. Yes.
So that gives you the knowledge how you can progress. So you begin with 5 centimeters, you go to 10, you go to 20, you go to 30, you go to 40. And then the progression, maybe in the beginning, you do the 6 repetitions, and afterwards you do the 30 repetitions. Or who knows, maybe a woman who does counter movement jumps and she does 30, it goes better than to do 6 with really high.
Really high, right?
Maybe. And then you begin with the 30, not with the 6. Yes. Who knows? That you do this, that works better.
Yeah.
Because you don't know for sure now what works really. And
right. No, that's important. Any other things that you want to be sure that we know from your work?
Yeah, I think that's the most important things we have seen.
Yes. I have a couple of questions for you.
Yes.
Since a lot of your work was published in the late 2010s, so 2016, 17, 18, 19, and around that time, the 2019 UK postpartum return to run guidelines came out. I would love to know your thoughts on, since you were very much in that space around the guidelines as they came out, and have you utilized them? How do you feel like it works in kind of the understanding of your research? Because obviously they didn't have all of that when they put out the guidelines.
Yes, our research team, was a little bit the black sheep, like this. So we are there and say, yeah, we have to train, introduce jumps, and people said, no, jumps, we can't do jumps. That's doesn't work. And for this, that there was something, we came with new ideas. And the good thing is, I think that also Carrie Burr, she does now a lot of research with pregnant women.
Yes.
And recently, her team does the research about high intensity training during pregnancy. So for me, that's a great thing that she that now does these studies.
Yeah.
So this is something that I'm really glad about, because she was someone who was quite skeptical against the jumps and introduced jumps into a training. So for me, it's really, I thought, I have seen this research. I thought, wow, great, she's doing this research. That's really, because that means that she is also rather for this. Maybe one thing I forgot about.
Sure.
Our research team did a research with incontinent women, and I think it was 25 or 50, did a normal pelvic floor rehabilitation training. And the other ones, in the beginning, they did the same thing, proprioception, and then this range, and they did afterward with jumps and running. And the output was the same, both. But it wasn't better. It was not worse. Huh? It was the same. That means it's you can do it. It's not worse. Right. And then the most important thing was 6 months after, the women were told once within the normal study to do the contraction, relaxation, contraction that we know, the normal pelvic floor training, and the other ones was told only to do jumps.
Right.
And after 6 months, the result was the same. So that's interesting, isn't it? That you can maintain the range of the pelvic floor with jumps.
Yep.
And the other interesting thing was the best results the women did in the first time with the proprioception training. So this is also interesting. A lot of proprioception, awareness of the pelvis, how to move the pelvis. I think that's why I do a lot with functional training.
Yeah, that's a nice crossover with, I think, the work that you do, influenced by the Franklin method. It's that's a lot of kind of understanding and feeling movement and functional sorts of things. It's a nice crossover with the research for sure. Looking ahead now, where do you think, now that we have more researchers looking at impact, and you're not the black sheep anymore, where do you think that we need more research? Where do you think it's going?
Yes, it would be nice to have some guidelines, like to say, yes, it's if a women have this and this and this capabilities, then you can begin to do this, and then the progression of the impact loads, to know more about this, if it's possible. Huh? I don't know, and to have a little bit more, because often in the studies they're right, they did a rehabilitation. They did pelvic floor muscle training, but
Right.
what have they done? We don't know. So
Right.
we are a little bit
Terminology. Yeah. Yeah.
in a cloud. We don't. It's not really. Yeah, we do something, but and then the other ones say also with strange training of the muscles. So
Mm-hmm.
the ones say, yeah, you have to do 5 seconds of contraction. The other say 10 seconds of contractions. Then the other says you have to do, I don't know, 15 times, 20 times, 30 times. And yeah, we have a lot of different
Right.
ideas about this. If it's important, I don't know. For me, I
Right.
think the most important thing is the timing, that you really learn
Yes.
to activate it.
Yeah. Well, and I wonder how much of the past research that does point to strengthening, how much of that actually is carryover of working on timing and coordination, and maybe isn't truly just strength, but I suppose time will tell. But it's so nice and refreshing to see that we've moved beyond just the pelvic floor and looking at, yes, we need to do jump training, we need to do these other things, we need to challenge the excursion and treat, work on the timing and all these other components, because we're it's more than strength. It's more than just that one thing.
Yeah,
So
yeah. There's another interesting thing. I looked a little bit about studies. Um, the fibers, the fast twitch fibers and the slow twitch fibers. And there are studies that the incontinent women they have more slow twitch fibers than the continent women. So this is also a reason that you have to train the fast twitch fibers.
Right.
Because we have seen that they have too much slow twitch fibers.
Yeah.
And another interesting thing would be, in my opinion, does it matter the differentiations between the different muscles?
Right.
If you the pubo rectalis or the pubo occipitalus muscles, if you are more training these ones,
Right.
or more the pubis bulgiosus and all these different muscles before. And then another thing I do, I think this is very important, is it's a little bit posture. But this I do always with the women. A lot of persons are more on the outward of the feet. Not on the big toe. They have their weight more outward. And then the tensor fasciolata is very active, and the glutes are very active, and also the spinal muscles are very active. So you are more in the extension, all in the extension. So outward rotation, more up, and like this, everything behind.
Yep.
And if you are doing jumps like this, you train also more these muscles. But we need more the adductor muscles, and we need more the flexion chain, like the big chains that come from the tongue down to the toes. That the facial, deep facial, yeah, deep facial fascia. Don't say no.
I know what you're saying. I know what you're saying. Yeah, the deep.
So we need to activate this. And there inside is the diaphragm and also the pelvic floor and the psoas muscle. That's why I'm a fan of the psoas muscle. And this for me is like also like ABC of my training of the rehabilitation. The food and the position of the food, and the women feel that they can activate the adductor muscles, and like this also the forward part of the pelvic floor and the psoas, and then that they are not too much on the outward and the piriformis and the hip rotations, the obturator internus too much, and the glutes too much. So this for me, I think is also would be an interesting research topic.
Yeah, no, for sure. For sure.
Mhm.
So you're going to keep somebody busy with the list of things to do.
Yes.
Now, for you, are you a runner yourself, or what activities do you do?
I practice capoeira. Do you know
What is
capoeira? That's a
no?
Brazilian martial art.
Ah,
And yeah, it's very interesting because you do also, you're singing, you do rhythms, and
uh-huh.
then two persons are playing together.
Okay.
And it's quite physical because
Yeah.
you go on the hands, you go, it's a little bit like, it's a martial art,
Uh-huh.
but a lot of people think it's like dancing.
Ah, I've
Yeah,
never heard of it.
you have to YouTube and then
Okay, I will do that.
capoeira,
Okay.
capoeira.
How long have you been doing that?
27 years.
Wow.
Yes. And I'm still doing it because the most of people, they do it, they are about 20, 30 years old.
That's wonderful. That's
Yeah,
wonderful. Is,
I love it.
do you do anything else, or is that that's your main thing?
That's my main thing. But now in these times, I do a lot of cycling,
Mm-hmm.
road cycling. I think
Mm-hmm.
it's like this. Yeah,
Yeah.
road. So I will go next week with friends of mine. We will go to uh, Ireland, I
Mm-hmm.
think it's
Yes.
that.
Uh-huh.
So we do the Ring of Kerry, and I don't know what.
Oh, that's
Yes,
beautiful. That's
yes, with the
beautiful.
bicycle.
You should go visit. I think is Michelle Lyons in Ireland, and also Grania Donnelly, I think, is in Northern Ireland. So you should go visit them while you're there.
Okay, yeah, we have sometimes afterwards, after cycling.
Very nice.
Who
That'll
knows
be
to
that'll.
go there?
I've been. It's a very beautiful place. You'll have a lovely trip. But,
Mhm.
well, thank you so much for sharing and taking a trip back into your work, and thank you again for showing us how you're using this and incorporating it with your imagery work, because I think that's such a unique way to put this all together, to take what we understand from research, but then also how we understand imagery and movement, and see if we can get a better outcome for our patients. So if people are interested in learning more, we'll post some of the links and references to the papers in the show notes. And thank you again for joining me. I appreciate it.
Yeah, it was a big pleasure for me. Thank you. And also, I find you do a big work, and I like your podcast. It's
Oh,
great.
thank you. Thank you.
Yes.
Thanks so much for being on.
Thank you.
If you're navigating pregnancy, postpartum, or perimenopause, whether personally or professionally, check out all our free resources and upcoming courses at carriepagliano.com. This podcast reflects the opinions of Dr. Carrie Pagliano and her guests, and it is for entertainment purposes only and should not be considered medical advice. Always consult your healthcare provider with any medical questions. If you enjoyed the episode, please take a moment to leave us a 5-star review on your favorite podcast platform. And thanks for listening.